Hello everyone, happy Wednesday. We are back for another fertility Q&A round with Dr. Kenneth Gelman of IVFMD. So he'll be joining us in a few moments. And if Dr. Gelman can join us under the IVFMD login, that would be great so that we can let everybody else know over on that side as well. So I see Dr. Gelman there, but we can hopefully join from the other Instagram because I see him on his personal Instagram. So hopefully we'll, I'm gonna go ahead and actually invite him through on my end. I'm gonna see if I can do this. Let me see, there's a, oh, there it is. Okay, let's see, IVFMD. I don't see any, okay, here we go, buttons, so I invite them. And also, I just want to say hello to everyone and invite you guys to type in your questions tonight too. So as we go in, oh,
there we go.
Hi, how are you?
How are you?
Welcome. And we are back tonight. So I was trying to think, how many weeks have we been answering questions? I think it's over a year now. Definitely it's been over a year. It's like a year and a half, but
isn't it that long?
I think so. I mean, we have so many good questions all the time that it seems like we never get to the end of them because we have to put them in a book.
Seems like there's more and more every time we do this.
Yeah, like I think it would be an awesome idea to put them in a book. It would be so cool. So if you guys please are welcome to type in your questions tonight. My name is Dr. Farrar Duro. I'm a licensed acupuncture physician and reproductive acupuncturist. I'm in Hialeah Gardens, and I work with Dr. Gelman's patients. And let's see, we've been working together many, many years, over 10 years, I'm sure, probably 15, long time. And we work with PCOS, endometriosis, IVF, preps, IUIs, natural fertility, basically just helping things work as well as they can. And Dr. Gelman is here tonight with us, so if you could just introduce yourself as well to those of you who don't know.
Dr. Kenneth Gelman, again, as I say every time, one of many doctors in IVFMD, and it seems like it's expanding all the time. And I'm in the Cooper City office with Dr. Wood and Dr. Gerkowitz. And again, there's offices all over, Broward and Dade and even up in Viera. We're happy to answer your questions. We're happy to do, any kind of virtual consults for anybody, even though if you don't have to live in Florida, you can live anywhere. And we're happy to do that.
Such a cool time we live in right now,
Yeah, it's great. It's absolutely great. Yes.
And also, I want to say that we did receive your questions earlier. So we have a lot of questions that we are going to get to tonight. It's going to be a little rapid because we have so many questions. And also, we will be posting this. So if you want to share this with your friends, you can share it so that they can join us live, or you can watch the replay if you missed any of them. We're going to post it on our Instagram and also on IVFMD. They post that, and on Facebook and on YouTube and on Twitter. we try to make it where everyone can find it, Yeah, just because some people are not on social media, so we want to make sure that they're able to watch it. Thank you guys so much for being here tonight. And so we'll get to the first question. Well, we can jump into the acupuncture questions because I know that those.
There was a lot of those. I saw a lot of acupuncture questions.
Yeah, and then I'd also want to get your take on what you see as the most beneficial as well for your patients who are doing acupuncture. Like what do you find that they respond to the most, I guess, when you're seeing them coming in for acupuncture? So there's a question about timing, and a lot of people do ask that, like, when is the best time to do acupuncture for an IVF cycle? So we look at our scheduling basically goes, if you know that you're going to do a cycle and you have a few months to prepare, we can actually do a lot of work in those few months. So for instance, we had someone calling today that they have a cycle coming up in November. So we have like a little bit of time. It's almost October right now, but we would preferably like to see that person twice a week. And usually that's happening between like 6 to 8 weeks prior to the start of either a FET or a stimulated cycle. And then throughout that cycle as well, because in general, IVF can be stressful. We know that there's, those factors as well involved. But we look for also with patients who have failed IVF cycles in the past, we want to try to optimize their nutrition as much as possible, their stress levels to help with that, and their blood flow. So as much as we can do to help you guys succeed and to help your treatments work better, that's what we try to do. And obviously there's no magic bullet. There's nothing anyone can promise that will be 100%, but we're going to try our best. And I think that, you know, with the treatments that you guys have in place, you're able to offer so much as far as that prep work, that preconception care that a lot of times people don't get other places. So, so yeah, if you can talk about a little bit about maybe your experience with that, with your patients, and what do you recommend?
Well, I think the most thing that they tell me is, I mean, I think yesterday I had a patient tell me that she loves acupuncture because she's so relaxed. Mm-hmm. She goes that they look forward to the sessions because, you know, obviously everybody's working hard and, you know, stress with all this COVID stuff, and, you know, you're struggling to get everything done that we ask you to do. And then we ask you to do acupuncture too, another thing. And then, you know, when they go, they say, this is great, you know, especially people who've been doing it for a while, and the longer the better. They seem like they're much calmer. And this particular patient, you know, I've known for a while, and she looks calmer. Mm-hmm. So I see that benefit, and I think, you know, fertility benefits aside, who couldn't benefit from being calmer?
I think we all need it.
I mean, you know, your nervous system's on overdrive. People's cortisol levels are probably astronomical. Mm-hmm. And, you know, that really helps reduce all that. I mean, you know, that's got to add years to your life. Just the stress reduction.
Yes, there's a
just the stress reduction. That's been looked at Harvard.
Yes, it has been studied. I mean, it actually lengthens telomeres. So that's cool.
Yeah. I mean, in DNA, right? Because of the stress and all the counter-regulatory hormones and things. You know, I mean, gosh, it's the best thing. I mean, if you can be calmer and more relaxed in everything you do, it's only going to help the situation. Because I always say to people, stress is the big intangible on this. We can't measure it really. I mean, maybe we can with your blood pressure and stuff like that. We can assume. But you can't really measure it and its effect on a fertility cycle per se. And I think, you know, there are situations probably where stress plays a role in why somebody isn't getting pregnant. And, you know, the old dictum, you know, people go away on vacation and they go away for 2-3 weeks and they go to the Bahamas or whatever, they get pregnant. Well, there's got to be something to that, I think. Yeah. So, you know, the benefits, I think, are far reaching, not just fertility benefits. They have so much other benefits on your overall health. And like, you know, we advise patients about your overall health. You know, you sit with the patients and we're looking at their labs. It's not just looking at their estrogens and things. We're looking at I look at their cholesterols. I look at their, you know, a lot of other things, their blood sugars, their A1Cs. I mean, we look at all that stuff. I mean, yeah, all that's important. And, you know, we're advising them on all that. Why not advise them about how to reduce stress? You know, because I'd say, and I've heard this quote, that 70 to 80% of doctor visits are due to stress.
No, that's not so. Even stress can elevate your cholesterol, your glucose, many things. And we work a lot with PCOS, both of us, so we know those things are definitely an issue. So I think that's one of the reasons it can work well.
So the biggest benefit I see is people are calmer and they're more relaxed. And they really appreciate, especially when you come to the transfers. I think that's the best. I
wish I could come to everybody's transfer. I'm like, I'll be there. I promise. If you want me there.
It really is such a good thing because.
Right. Yeah. And I think too, like when you know ahead of time, you have a frozen embryo. Well, most of your transfers now are frozen. So you have some time. And like, for instance, someone who said, oh, I feel like this month is not, I have a lot going on during that time of the transfer. There's going to be a lot of stress in my life. I'm moving, my job's changing, got a lot of stuff going on. And they're thinking intuitively, this is not going to be a good time for this transfer. And it's like, well, listen to your intuition. You know, maybe you need to talk to your doctor and move that transfer back sometime. You know, you know your body. You know when things are not right.
That's a really good point. I mean, I think that is something absolutely what I think is a great benefit for a frozen transfer is you can plan it. You know, you can plan the whole thing. And I say to people, I said this yesterday too. I said to this lady, take 3 days of bed rest. I'm old fashioned, you know. Some doctors will tell you, you know, go do whatever you want. I mean, that's been, I've heard that, you know, but I'm very old fashioned. I say to patients, take your 3 days of bed rest, take a week if you can get it. You're spending all this time and effort and emotion and money. Why not make this work and do everything in your power to help
harm, right? Yeah, there's no harm in relaxing.
If you can get the time off, do it.
Yeah, that's true. And the person who just asked, could acupuncture be done on the day of frozen embryo transfer? That's something that we just talked about, and we do like to be there. We'd like to be present. I do work with an associate doctor, Aracina, which I know that you probably met her at the office, and she helps a lot because there's only like 2 of us. She's in Coral Springs. We have another satellite location in Coral Springs, and we're in Hialeah Gardens. So we do have patients in the Miami office when that's very close to me. So I do end up going a little more there, but I do go to Cooper Study when I can, and she also does. So there's 2 of us. So we usually try to make sure that we're there for our patients if they need us to be. And if you can't do it on the day of transfer, we can always do the acupuncture as close as we can to the transfer time. Like maybe you come in the morning to the office and you go to your transfer in the afternoon. It's not, I mean, it's really like, it's okay. We don't want to see someone after their transfer. I don't want people to rush to our office and all that. I just want you to go home and relax.
Yeah. Some doctors, some acupuncturists advise that, and I always tell them no.
I don't.
I say absolutely not. I think you go right home and get into bed, and that's it, you know. And the best thing is the acupuncture, obviously, at the time of the transfer, right before and right after.
Yeah, and we've had cases where patients have very difficult cervixes. So like it's very painful for them to have catheters inserted. So the acupuncture seems to have helped, you know, with that. And I think like there are points that we choose they're not our points, they're actually from a study, but we do them that help relax that cervix so that it is a little bit more comfortable, hopefully. And if you're relaxed, you're going to be less tense down there as well. So
correct.
The same as when you deliver the baby. It's like what can help get the baby in can help get the baby out. So we tend to do those acupuncture points also. Ironically, we do them to help people prepare for labor. So there's different strategies. And that second treatment is actually the opposite, where it's prevention of contraction. So there are certain points that can only be done at that moment. And then after that, no more until you're ready to deliver. So it's a very interesting type of treatment that is from Germany. That was from a study done many years ago that was repeated several times. And it's been very effective. So we don't deviate from that, like, because it works really well. And I just tend to follow that same protocol. But we also then treat our patients after the transfer, like 4 to 5 days after. And, you know, those points are actually pregnancy points. Like we are assuming that you're pregnant, and we're treating you with those points that we would use for during pregnancy. Right. And a lot of them are very gentle. They're actually for prevention of nausea, vomiting, for stress relief, for circulation. And then we can still treat low back pain. We can still treat migraines, patients that have migraines that are now told, oh, you shouldn't take anything because, you know, you could be pregnant. We're going to be doing migraine, you know, preventive points. So, so that's what we try to do. As far as that was the question about that, how long before a frozen embryo transfer should I start acupuncture, is really as soon as you can. I mean, if you have like 2 months, that's perfect. 2 to 3 months would be great. Some people have really complicated issues where they've got some inflammatory things going on. They have some weight that they'd like to lose prior to doing their transfer. They're working maybe with a nutritionist, or maybe they're doing it on their own, and they have that inflammatory markers that are kind of showing up where they need to work on those. Their thyroid might be out of whack. There's many things going on that you guys are monitoring, and that they need to wait a little while so that everything can kind of calm down. And that's the great time to do acupuncture while you're trying to work on all those other things.
Oh, absolutely.
You know, it can help.
Yeah, while they're getting prepped.
Right.
You know, because there's plenty of patients that are prepping, you know, getting ready for all this, and, you know, improving themselves nutritionally, etc. That's a good time to start. So 3 months is optimal, I think.
Yeah.
To get this done twice a week.
Yeah, and as far as the, I'm just trying to like kind of get all the acupuncture questions in, and we're going to get to all the other ones here, because there's just basically, most of them are about timing. And I would say also, like, if you can't do twice a week, then it's okay to do once a week. It's like, get something in, whatever you can get in is good. And then, during that time, if you're stimulating your ovaries, that's a lot of things that you're kind of putting in, as far as like what your ovary usually only produces one dominant follicle a month, and now you're asking it to a lot of things, like let's produce 16, 20, so there's a lot of things going on. You need a lot of blood flow for those medications to get to where they need to go, and so we do increase the frequency at that point for sure during stimulation. So I think,
so just to clarify that person's question, we do recommend acupuncture directly after the frozen transfer when you're there.
When you're there,
not going to the acupuncturist, office when you're finished with the transfer. Yeah. But you have the acupuncture right there, right after your transfer, that the acupuncturist is in the transfer with us, or, in the adjacent room, and comes in when we're done. Yeah. That's fine. That's what I recommend. But not to travel. When you're done with the transfer, you go right home.
Especially Miami traffic, horrible. Yeah. I don't want to do that. Just go straight home. Yeah. So hopefully that helps. And I think those were the main ones that I saw here. There was a couple supplement questions as well. And the question was, do you recommend L-Arginine for DOR?
Yeah, that's a good question. There's a lot of anecdotal data about L-Arginine. L-Arginine, is an amino acid, but what it does, is it it's supposed to increase blood flow to, in the uterus and, the uterine arteries, etc. And anecdotally, it probably helps, increase growth hormone to a certain degree. But the studies on that are small and anecdotal. I think there was a good study out of England that looked at IVF people that took rather high doses of arginine and had more eggs retrieved, but the pregnancy rates weren't necessarily higher. Very small study, and so I mean, if you can tolerate it, it's probably reasonable to take that in somebody who has diminished ovarian reserve, where we think the ovarian blood flow might improve, because if you increase more of the blood flow by generating nitrous oxide, that's how it works. You might recruit more follicles. Obviously, more blood to the ovaries, more hormones get there, more eggs could get recruited. But the doses that they used in some of these studies were really high. It's like 17 grams a day. Now that's a really high dose. I mean, that's hard to take all that. Mm-hmm. Sometimes I recommend 6 grams a day, which is not anywhere near that. But you got to be careful with L-Arginine too, because it causes low blood pressure. It can drop your blood pressure. Mm. So if you have low blood pressure, you might, find yourself getting really dizzy. And also, if you have herpes, genital herpes, it can cause an outbreak. So, you got to be careful with that too. But I've used it, and certainly in situations where you have a frozen embryo transfer, it might be useful. Where, it's been shown, I think in one study I saw, that you can actually increase the Doppler flow to the endometrium, the uterine spiral arteries, seem to be more prominent in people who use L-Arginine, and thickening the lining in people with thin linings, which is, a fairly common problem sometimes. And that's kind of in place of Viagra. Viagra was supposed to do the same thing, but that never really caught on. Okay. So L-Arginine might be of use, but the question is, what's the dose? Nobody really knows, I don't think. And, how can you tolerate it? It's just a high dose. So,
yeah, and the premise is that it increases circulation. So you want to do things that increase circulation on a regular basis instead of impede circulation. And impeding circulation would be like smoking, over-exercising, getting stressed all the time. And, those sort of things are not great. So I think that's where that can be beneficial. But if you're also a heavy bleeder, that's you got to be careful with L-Arginine too. So if you
it could be problematic. But I think the main issue is figuring out what dose really will work, and how do you really know, and how much can you tolerate. I think that's going to be the main thing, unless they figure out some way to get this, you know, in a smaller, more compact dose that could be tolerated somehow.
We like to use FH Pro. I found that to be one that has a lot of different things all in one, by Fairhaven, I believe. So I was researching something that has alpha lipoic, CoQ10, myo-inositol, all these things that actually are good for improving egg quality, and melatonin that you can take in one thing. So that's kind of one of those that I like, but I know everyone has
those are good, but the problem is it's not going to have enough probably of L-Arginine or some of the things that we
it doesn't
really
have
want to use.
L-Arginine. Yeah, it doesn't. You might have
some
to
of those
take
some of those things you got to take that separately.
Mm-hmm.
And the dose of coenzyme Q10 that they use for DOR, which is getting off the subject a little bit, you know, is high, 600
Mm-hmm.
milligrams. So you know, we have to sort of make little adjustments. Everybody has to take separate vitamins for these things. But we're getting off that subject.
Yeah, I mean, we could talk about supplements for a long time, but I thought, you know, that if you're looking for a basic one to kind of start with, that one, you know, at least has methylated folate, it has, you know, all the good things in it. And then as far as, okay, we have a few questions here. Hello, 9-week ultrasound was good, heartbeat and healthy embryo, chance for good pregnancy? I'd say so, yeah. Right?
Well, it sounds great. Yep. It does sound good.
Congratulations too. That's very good.
Yeah, that's a good thing. So be happy and just keep doing what your doctors tell you.
That's awesome. And we have a question that I posted below. My only problem is that I'm not getting my period and I'm not ovulating. Help.
Yeah, well, that needs to be looked at. I mean, you got to see your doctor about that. You're either a gynecologist, maybe your internist even, and or come to us. You know, we'll get you going. And we'll figure out what you got, and we'll get your period going, and you know, make sure you ovulate.
There were a few more follow-ups to that question because it was on the Q&A. It says I have PCOS and Clomid is not working for me, or Femora. Any thoughts on Maca? Okay, so you know, I mean, there's like other things at play. If Femora or Clomid doesn't work, what do you think is happening there?
Well, sometimes I combine the two actually, Clomid and Farrar together. There's been some reports I've done that in a few patients. That might be one option. And then obviously if things are not, you know, going where they should be going, then, you know, we have other methods and other things we do, like, you know, injectable drugs and things like that. But, you know, in somebody like that, we got to be very careful with that because they can start to, you know, stimulate a lot of follicles to grow. And, you know, that could be a little dangerous to ovulate somebody in that situation. So, you know, that person might, I'm not saying might end up doing IVF because of the fact that they're hard to stimulate the ovaries to develop those follicles, which, you know, with PCOS, there are some individuals, obviously, subsets of PCO, very difficult to stimulate, very difficult. No matter what we do, we put them on metformin. The old way to treat that many years ago was the ovarian drilling procedure, where we take them to the OR and we put little. Well, and years ago they used to do actually a wedge resection. They used to take out a real chunk of the ovary, but that didn't work too well because that, you know, is putting people into ovarian failure basically.
She's saying she has 60 follicles. Yeah.
And then, you know, but now they, you know, some people still do that. They actually put little powder burns on the surface of the ovary. But still then I've seen people, you know, have trouble with that too. It doesn't work. So, you know, that's a tough case. And, you know, that usually requires specialists and specialist help. So if you're not getting, you know, enough help from your gynecologist or, you know, come see us, we'll help you.
Dr. Gelman's awesome with PCOS too, I have to say. I have a podcast and he's been on there a few times. I haven't updated that podcast at all, but it's all about PCOS. And we talked a lot about, in length, about really what to do when you have PCOS and you're going through IVF and how to prepare for that. And, you know, nutritionally what to do, because that's really important too. I mean, that's the crux of it. A lot of it times with PCOS, that's the hard part, but it definitely helps with that. And so she said she has over 60 follicles, which is, you know, that does sound like PCOS.
Oh, definitely. Yeah, definitely. That, you know, you probably need specialty help. So I would go to somebody that's, you know, in a reproductive field that could help you better.
All right. And another question here. It says, are you located in Florida? Yes.
Yes, we are.
Dr. Gelman is, if you go
South
to
Florida.
IVFMD.com, there's all the locations
Yeah,
there.
we're in South Florida. My office is in, west of Fort Lauderdale, in the South Florida area.
Okay, we have so many questions. Let's jump back into our question list from earlier, and then we're going to go to you guys as well, because there's one about the last one about what supplements can help boost fertility health. We talked about a few of them, or food. I think you and I both agree, like the Mediterranean diet is pretty helpful for our patients. They've been really and that's naturally anti-inflammatory. We try to eliminate a lot of processed foods as much as we can. A lot of patients are already doing that. We give our patients recipes when they come in. That's actually, we work with metabolic codes. So these are recipes that are actually meant to help balance blood sugar. We do start off with, just for at least the first month, these recipes that they can kind of work with their partner on, and has shopping lists, it has smoothie recipes, things like that, and at least to get started. And a lot of people are also seeking a nutritionist, so you guys have awesome nutritionists there as well, and if you are doing that, then that would be also more specialized, but I think that definitely, that's just to start with. Try to clean up that, and we take out also the sodas and any kind of
the main thing is try to cut back on sugars. I mean, I think that's the easiest, most obvious thing. Soda, big one. You're right. Soda's a big one. Drink some sparkling water, put a little lemon in it, do something like that, and then, the sugar. I mean, your breads, cut back on breads and processed foods like that. Yeah. The most obvious things.
So, so as far as supplements, that's a whole nother thing. And I think we just kind of brushed on that, but mostly CoQ10 has been one thing that's been recommended, and also prenatal with methylated folate and good fish oil, probiotics. I know you guys also recommend, and to definitely check vitamin D levels. That's important too. Right. Do you recommend a certain threshold as far as, is it like 40 to 60 NGs, or what is something that you guys recommend for vitamin D levels?
Well, they have a protocol that the nurses follow, but generally, I mean, I'd keep it in a normal, certainly over 30, but keep it maybe around 40 or 50 would be better. I think probably on a little on the higher side maybe, but obviously if somebody's got a history of kidney stones, you got to be careful. You don't want to overdo it either. But I think the nurses generally follow that, and they have a specific protocol that they use based on what the level of vitamin D is, which just about everybody's deficient. It's amazing. Especially in Florida, you find everybody's deficient in vitamin D.
Everyone is, and they assume we're not, but we are. We'll have UV coated everything. That's what it is. So we have a question here. 31, I have 4 different AMH tests. 2 of those were 0.9 and 2 were 2.3. What can that even mean?
Oh, that's a good question. That's a good one.
Yeah. Trying to conceive for 1 year, 2 rounds of letrozole, 1 round of trigger shot with no letrozole. Should I do IVF next?
Is that the same question?
Oh, yeah.
With the AMH? With the so she's had 2 different AMH levels?
Yeah, there were 2 were 0.9 and 2 were 2.3.
That's crazy.
Yeah,
we've covered this numerous times in these talks. And that's a very important point to make, and we should probably make it again, is that AMH is only as good as your assay. So make sure, your assay may not be very good. There's a big difference there. Why is there such a big difference in those AMHs? You're not going to go from 2.3 to 0.9, in 6 months. That's very unlikely, unless you had some kind of, treatment that injured your ovaries or something. So you've got to look at you got to find out, you got to ask your doctor, was that an accurate AMH, and, what's your antral follicle count? Does it correlate with that? Because that's where doing an ultrasound on day 3 and antral follicle count with the doctor will tell you whether that AMH is accurate or not, because we can look, and, we look at a lot of ovaries, we can tell whether somebody's got poor ovarian reserve pretty quickly. Yeah. And, whether that AMH is going to correlate with what we see. So because there's sometimes those AMHs are wildly inaccurate, and people come in and they're crying because they don't feel they can get pregnant, they need donor egg, da da da, and it may not be true.
Mm-hmm.
And this person isn't getting pregnant with Femara, or is that what you're saying, that she got a trigger shot and she's not getting pregnant?
Right.
I mean, that's not unusual. It's even people with good AMHs, So, it depends on your age, how long you've been doing this, and I've said this before, what your emotional status is, how anxious you are, any medical complications, there's, is there any male factor? A lot of that has to be taken into account, whether you want to proceed to IVF next, because IVF is sort of the big fix-all for everything, really, and get you there the fastest, no question. So, there's a lot of factors that go into it, but not that you can't do IVF anytime. You could walk into a reproductive office and do IVF if you wanted to, right from the get-go. You don't have to do all these other things, but most people obviously start at the basics and move their way up. So, that's a good question, but, that's something you should definitely talk to your doctor about, your AMH levels. I think that's something we got to make clear on these things, is that's a very important point.
Yeah, and at 31.9 is, like, if you're 31
Yeah,
years old.
that's very, very low for a 31-year-old. 2.1 is sort of low too, but not terrible. That's obviously a lot better. At that age, it should be 3 or 4, more like 4, I think. So, that person probably has a little DOR, but it may not be as severe as she thinks.
Yeah, and we said AMH is not the be all end all either. Like, that number can fluctuate. It's really based on so many other things. So definitely, hopefully she's getting ultrasounds done and they're seeing, what's going on in there, but definitely, don't just go by the AMH.
Right. And then the other thing is that in younger women, sometimes the AMH is not accurate either. It just isn't accurate.
Oh, she's saying they were 2 months apart. No, they were months apart. The first 2 were 0.9 and the next 2 were 2.3. So
yeah. It makes no sense.
Yeah.
There's something with that lab.
That's true.
And the 31-year-old probably is fertile and probably doesn't have DOR. And I don't know if I'd go by that AMH very much.
And we have an MTHFR question, and she is she says Medinex is not available in the country that she lives in, and she is positive for MTHFR. Should I continue taking prenatals or take folate instead?
Well, you should take the methylfolate, which, you should get, even if you have to get it shipped, and make sure, but you need your homocysteine level checked, because that generally, if your homocysteine level is high, you should make sure you lower that with active folic acid, because you're not converting very well. So you need the active folic acid to help lower that, so you can convert to active folic acid, and not have these issues. So that should, you should have it, somebody ship that from I don't know what country she's in, but maybe somebody can send it.
You can put it in the chat where are you? Where are you located? But as far as the prenatals now come with methylated folate too, a lot of them.
Most of them do.
Right.
Most of them do, so she should be okay, but some of them don't.
Oh. Does she need extra? Like, Medinex is actually a higher dose of folate, so would she need to take extra prenatals, I guess, if she doesn't have that sort of thing?
Oh, she's in Trinidad. Yeah, I mean, I think the milligram or 2 milligrams a day is certainly adequate in that case.
Mm-hmm. Awesome. And then you guys, even if you're in Trinidad, you can do virtual session, like you said, with Dr. Gelman or the provider. Yeah. I know you guys are super busy, but I think that you can definitely. Usually we say get on the cancellation list if there is no appointments for you guys, but but definitely I think it helps to get another pair of eyes looking at things as well. So no matter where you are, as we said, you can get help. So. Okay, we have a question. Does Lupron taken about 4 to 5 weeks before FET stop the normal ovulation process in preparation for the transfer?
Well, what kind of Lupron? If you're talking about depot Lupron, depot Lupron, and if it's the month injection, that might last a little bit longer than 4 weeks. So yes, that could interfere with your transfer. But if we're prepping you for frozen, it might work to your advantage, because we can just prep you while the Lupron's wearing off, and you won't ovulate, and then transfer your embryo. So it may not be a problem. Now, again, depending on the kind of Lupron you've gotten. If you got a 3-month one, I think that would be delaying you, up until 3 months, 3.5 months later. So it's hard. That's a hard question to answer. I don't know the details.
Yes, and I'm going to.
Oh, sub-Q daily, she wrote. 10 units daily. No, that shouldn't.
Okay. Okay. And then as far as the other questions that were put in earlier, I just want to get to a few of them. Is it possible to ovulate after a miscarriage before a period? Experience symptoms?
No, not usually. Not
Okay.
usually.
Okay. And what are we looking for when picking an acupuncturist, other than they do fertility? I guess you can answer that. What do you look for with your patients when they pick an acupuncturist?
I know you're answering that, not me.
I mean, I think that they should work with fertility patients on a regular basis, I hope, because it's really, I think it takes also, working on this quite often. I mean, because like, I guess the example is like, if somebody came in and they were undergoing cancer treatment, and, I don't treat that. I don't know enough about it to give herbal recommendations, to do those things. I mean, I can probably, help with pain, and I could do a basically good job, but I will refer them to a colleague I have who works with cancer patients at Memorial, breast cancer patients particularly, and she's like phenomenal, and she's very good with that. So I think working with a certain thing over and over, it does help quite often when you know what your patients are taking and the timing of everything as well. But also certain points that are useful, that have added benefit. We have so many points to choose from. There's over 400 points in the body if you count extra points, and then so there's many of them. But a lot of times I'll have patients come in and say, I've just got I've actually never done a back treatment before, and there's a lot of great helpful back points in acupuncture theory for painful cycles, irregular cycles. I like to do a electroacupuncture back treatment on the sacrum prior to a retrieval, because that point, like when someone is about to have a retrieval, they are extremely sensitive. Most patients, they don't want more needles going in their abdomen. They've already had a lot of that, and they're bloated. They don't feel good, and so we try to do a face down treatment to help more with blood flow without making that person uncomfortable. So there's just little strategies that we try to work with. And then also we have to have a certain amount of CEUs every single year in reproductive medicine. Most of us are members of ASRM, so we go to those conferences. Well, before COVID, we would go in person. Now we're virtual, but we look at research all the time because we want to recommend the best things for our patients. So make sure that acupuncturist is doing those things if possible, and also if that person is comfortable working with you during pregnancy, because there are some acupuncturists that don't want to treat pregnant women. It's not that they don't want to, they just don't really feel comfortable with that. And usually in school, the fear is put into you about doing anything that would cause any harm to a pregnant patient. So so you do need someone who has that training, or who's taking care of pregnant women on a regular basis. So and the place I always refer to is aborum.org. It's this American Board of Oriental Reproductive Medicine. That's where we are certified, and that's where you can find us, most of us, who specialize and work with IVF clinics all over the world. So if you go there, you're most likely able to find somebody close to you, hopefully. So and
let me add one point there. Dedication.
Mm-hmm.
I think somebody like Farrar is dedicated and really knows the field and is very experienced. Experience. That's what I want to say too. The more experienced, the better, and the more dedicated you are, the better. Because, again, you're the type of person who would help, and come to the transfers. Some acupuncturists won't do that, So I mean, there's a lot more, benefit by going to somebody with your experience, because this is a 24/7 field. This really is not, Monday to Friday, 9 to 5. We're getting, as doctors, we're getting emails all the time, and we're getting called all the time from our nurses, whether we're in the office or not. And we're answering questions and helping people. So that's got to be part of this. A very important part of this is dedication and a realistic feeling that it's true, that it's real.
Yeah, that was for sure. So I think in general, if you can, also have someone communicate with your doctor, that's really important, because a lot of times things come up and we need to ask questions. So we need to be able to keep the communication field open about certain things. So that's really important. So those are our little list there, but thank you very much for that. And I think in general, there's another question here that says, what is an appropriate number of embryos after the first IVF, and how to improve the chances of implantation with the frozen embryos?
Well, that's a hard question. I mean, again, a lot of that's going to depend on your age and your ovarian reserve, and any one particular cycle may be great, and any one particular cycle may not be so good. That's life. That's biology. You're going to have ups and downs, just like you have everywhere else. You have it in IVF too. So, I'll even say to a 20-year-old, you may not have a good cycle. You may not have great eggs this month. You may have one embryo. I've had plenty of cases, unfortunately, over the years, where people, were expected to have 7, 8, 9 embryos, and they end up with one, that's, maybe made it to blast or genetically normal, whatever it may be. So the question, and anytime you get one, it really is a victory, because there are a lot of abnormal embryos in this field, a lot. But, again, that's why it's always good to try to get these things done when you're young, or freeze your eggs when you're young, so that you have more chance of having a lot of embryos, normal embryos. So the question, that's a hard question to answer. But, as far as prepping for FET, we talked a lot about that already. Good health, good eating habits, stress reduction, keeping your weight down, adequate prep, obviously, making sure you're taking your medications appropriately, and your endometrium thickens appropriately. You don't have any hydrosalpinges or anything in your tubes that could affect your implantation. You don't have polyps, fibroids, all that's been checked. You don't have endometritis in your uterine lining. All those things have to be looked at before your FET, and that's kind of what we do.
And we have a few more IVF questions here. Your thoughts on starting IVF cycle with birth control on a patient with DOR who is prone to cyst?
I don't like using birth control pills in DOR patients. I mean, on occasion, you might have to do that, for a very short course. But certainly not for a long time. But I try to avoid it like the plague. And I try to we use a lot of luteal estrogen priming, where we put patients on estrogens after ovulation and program them that way, because estrogens seem to act a little bit like rocket fuel and tend to, enhance the antral follicle count for the following cycle, and maybe a little testosterone with it. So that's what I tend to use, and not birth control pills. So if can be possible, sometimes ovarian cysts, aren't that problematic, especially if they're kind of smallish. On occasion, when somebody's about to start their cycle, we may drain it, maybe that'll help a little bit. But, sometimes we don't worry too much about cysts.
And we have another question about regards to IVF. Looks like what's the role of Lupron prior to FET how long before FET should you start it?
Well, it depends on your prep. I mean, we have a special protocol or prep that we use that the nurses follow, and you're prepped with Lupron. Once you start birth control pills, and you're on it for several weeks before you stop it. So it depends on what your clinic does. I mean, there's different ways to use that. Some clinics don't use Lupron at all. Sometimes we actually don't use Lupron. We do more of a natural cycle transfer, where we might, just let somebody ovulate, or we put them on Femara to try to get them to ovulate, and don't use any Lupron, and transfer the embryo. So it depends on your protocol, what you need. But typically most frozen transfers are programmed to use Lupron, for various course of time, depending on your clinic, before it's stopped, and the progesterone, etc., started.
Yeah, and a lot of the questions that I'm looking at are definitely very specific as far as what medication would be better. I think that's where the art of this comes in. Like, you're a person, you're going to have a different protocol than your friend probably, that's why you would go and get everything reviewed beforehand. And what some doctor does in another clinic might be totally different than what you would do, right? So
yeah, it is, and that's why we've talked about ERA tests before, and an ERA test from one clinic might give you a different result in an ERA done in our clinic.
Okay.
So sometimes, because their frozen transfer prep may be different.
Okay.
So
that makes sense.
Yeah, so everybody has a little bit of a difference in how they prep patients with frozen transfers.
And there is a question about coffee. Egg retrieval in November. Should I stop drinking coffee? Only on 2 cups weekly.
2 cups weekly is probably okay. I mean, it's not supposed to be more than 2 cups a day. So you're having a cup, couple of cups a week. I don't think there's a big problem there.
Yeah, definitely. And I think we had this question earlier with Dr. Wood. She recommends 1 cup a day. Like a
One what?
1 cup of coffee a day, I think, was like her maximum. So
I tell them not to have that, or I tell them to have decaf or half and half or something like that. They start weaning off, because I think in pregnancy, again, I'm an old-fashioned guy, and I tend to try to be as natural as possible. And when I hear things about miscarriages, I don't like hearing that.
Yeah.
So I tell people to try to cut back as much as they can. I think 2 cups a week is certainly fine. Or if they're going to have it daily, maybe a cup of decaf, or at least half and half.
Yeah, definitely. And we have a question about, is Femara better for women with PCOS and trying to conceive? Just finish this round using I think she's saying, I'm not sure what the last word is, but it's asking about Femara, maybe better versus Clomid, I guess. Yeah.
Yeah, I think it's better for PCO. It seems to have higher ovulation rates. Clomid has a different mechanism of action than Femara does, and the problem with PCO is they don't make FSH very well. They tend to make more LH, and Clomid raises LH and FSH together, while Femara will just sort of raise your FSH so that you make a follicle. I think it is a better drug, and it's been anecdotally said it is. But on occasion, we've used Clomid. I mean, in PCO, it's been used for years, I guess, and before Femara was popularized. So, but I tend to use almost exclusively Femara in everybody.
And basically, it doesn't have a issue with like thinning the lining and things like that.
Correct. You can also use multiple cycles of it. It won't thin your lining out. It's a great drug. It really is.
And there are a couple of questions about what's a good normal first beta. Like we have one in the chat, and also another question someone submitted earlier. Like, is there a range that you think is good for someone who gets their first beta? Or
well, I usually like to see them 250, 200, 250, but obviously we see them lower, and they do go to term. But, you know, sometimes you always get a little concerned when you see a low beta like that, you know, it's a poor implantation, or God forbid there's something worse that's in the tube, or, you know, whatever it may be. So I like to see it, you know, over 100 for
At least triple digits, right?
yeah, that's where I like to see the first one from frozen. Yeah, you know, in a natural pregnancy, 25, you know, 50, you know, but not in a IVF pregnancy.
IVF, no. Yeah, someone asked, is 326 good? You know, for
If
the
that's your first beta, that's a good one.
Yeah.
Yeah.
And chances for natural conception with controlled PCOS and 25 million sperm, recommend IUI, or recommend IUI.
What was that?
What's the chances for natural conception with controlled PCOS and 25 million sperm?
Well, if you know, if you're ovulating, I mean, you know, that seems fairly reasonable, and your tubes are clear. You know, with PCO, I mean, if you have PCO, you probably don't ovulate so great. So maybe a little femora in combination with that great sperm you got there, that might do the trick.
Yeah. So the question was, would you recommend IUI? So maybe something you said in combination. But again, like, it'd be good to get evaluated too, because who knows what else is going on. So good to get that. And a question about, what does homozygous C677T do while trying to conceive?
What was that? Oh,
I think
for the MTHFR?
Yeah, 3 recurrent pregnancy losses. The person has said that.
No, I think, if I'm not mistaken, and again, I can't remember the number sometimes. I think that's the one that may not be problematic in terms of thrombogenic. There's a variant that is, and I'm not sure if that's the number or not. You know, if there's any concern about that MTHFR or that particular variant, you can always have a hematologist comment on that, and see whether they think it's significant enough to put you on Lovenox.
Okay. And then we have a few questions here that we are getting down to the last few minutes, so we'll see if we can answer these. The FET next week, and have a massive migraine this week while on estrogen prep. Can I take Imitrex, or what else do you suggest?
Well, yeah, while you're on prep, sure, you can take that. And I think Imitrex is okay in pregnancy, but you got to check with your OBGYN on that. But right now, while you're prepping, absolutely take it.
And I'm definitely
No sense having a migraine.
Yeah, and acupuncture, if you have an acupuncturist, like, definitely tell them.
There you go, acupuncture.
That works usually pretty well, hopefully. So hopefully they can take care of that for you. And you can do that during pregnancy too, so that's a good thing. Okay, and then why hot baths or heating pads, why are they bad during the first trimester?
Well, I wouldn't encourage miscarriage and things like that. I mean, I think that's probably potentially what it might be doing, is, you know, potentially mobilizing uterine contractions in some way. So I don't think I would do that.
Yeah, you want to avoid heat or fevers or saunas or hot things in general.
Yeah, I wouldn't do that.
And then we have like, I think we're down to our last couple of questions here. What is the meningococcal vaccine recommended during pregnancy?
I don't think that is one that is, and that's a question I don't think I've gotten, because I haven't really seen any questions on that over the years on meningococcal vaccine.
Yeah, we get a lot of COVID vaccine questions.
Yeah, you know, that's kind of an interesting one. I don't think it's recommended in pregnancy. It's certainly before pregnancy, I would consider, but not during pregnancy.
Okay, and then
the flu vaccine is. So the flu vaccine is definitely recommended during pregnancy. So definitely get that.
And the question was, I just did my first FET. I'm having slow rising HCG. Is there any chance everything is still okay? So the first, it says number 1, 10 days past transfer. Oh, the first beta was 50. The second test 4 days later was 281. The third test 2 days later was 370. And then the fourth test 4 days later was 783.
Yeah, that could be a little problem. I mean, I think I'd keep an eye on that closely for any symptoms that could be an abnormal pregnancy or possibly an ectopic. So I'd be taking precautions there and being, in close contact with your doctor about that. If any spotting or bleeding, pain or cramping, make sure you get in contact with your doctor and get that checked out, because that might portend, something that may not be desired.
Yeah, so don't go out of town right now. Just stay close to your doc there, and we wish you well. Actually, we wish you all the best with that. I hope that everything is really good with that, and that is actually all of our questions. So if you guys have any more questions, you can type them in the chat. We finally got, actually we did like lightning rounds, so we got through them pretty well. I think there was one more here in the chat here. I think we'd actually answered. Yeah, we answered that as well. So wow, that was great. So actually, that's awesome.
Wow, we got through all those. Wow.
We did, yeah. We had several. Oh, I think there was. Oh, sorry, no, we didn't. There was a few more that I missed. Okay, I'm going back. So I had thought that we'd gotten through all of them. We still have like a few more minutes, so we're going to answer the last few here. A balanced translocation, 2 miscarriages, trying again before IVF. Any thoughts or suggestions?
Well, I'd probably do IVF and do the PGT, and get the proper genetic counseling involved, and make sure you don't have that problem again, because there's definitely a risk of you having that again. Why wouldn't you do IVF at this point? And work with a geneticist, and that way, we can probably do the best for you to prevent that problem from occurring again. That's not fun, having a miscarriage, and you don't want to go through that again.
Yeah, no, great. I mean, and I was thinking today, how many choices are available now that were not available before? We have so many choices now. So
of course,
so that's
it's not that you can't get pregnant; you want to stay pregnant, and that's a good way to do it. Yeah. So that's something I would consider very strongly.
The miscarriages are the worst part of our job.
Oh, horrible!
And our heart breaks every single time we see one. I wish.
Yeah, that's not a good thing.
And is feminine wash, i.e. Summer's Eve, safe while doing IVF?
I wouldn't use any of that during IVF at all. I would not, because you don't want to contaminate anything, or possibly the vaginal vault or the endometrium, anything like that. So I wouldn't use any of that other than what you're recommended to use, during your IVF prep.
Very good. And do you recommend Letrozole if I didn't have success with Clomid? I don't know if we got to that question or not. It looks familiar. But
yeah, we kind of did. We kind of did. Yes, definitely try Letrozole. Definitely try it. It probably will have a better result.
And then we have a question of why do some doctors do transfers without ultrasound?
Good question. I would never do that. I don't know why. If you have the ultrasound, I'm sure you've got ultrasound in this machine. Why wouldn't you use it?
That is strange. Yeah. I have heard of that too. I don't know. That seems
well, maybe in the old days before they figured out ultrasound and how to do it, but not now.
Yeah.
There's no reason not to.
Yeah. So, and maybe you should ask the doctor that, like, why are they not using it? I mean, because that's confirmation.
Or go to somebody that does. Yeah.
Yeah. I mean, if there's an option, or I'm not sure, but there. Yeah. That's confirmation the embryo has landed, right? I mean,
well, you're seeing where it goes in. You can see exactly where you're implanting it. I mean, you can see the little bubble, and you can see you have a beautiful transfer here. So, you don't want to take a risk here and know that it's not going in the right place.
Yeah. And I think, let me just double check here, that, Oh, great. Okay. I just saw that someone is coming to see me next week for, oh, great. Yes. I'm going to her transfer. Yay. Okay. Well, that's awesome. I am excited to to meet you. What level of vitamin D3 is considered too high? Is 98 too high? It is high, I think.
That looks a little high, yeah. You're probably on too much, so cut back on your dose and get it rechecked and keep it